to call the meeting to order, and I would like to have Diana.
Thank you. Can everyone hear us online? Okay, wonderful. Thank you for that confirmation. Dr. Dee Gillill.
Here.
Thank you. Brett is it Kelly? Kylie. Thank you very much. Jeremiah Lindeman.
Here.
Dr. Sheila Manicki.
Here.
And Dr. Lisa Winkler. Thank you. And then for the Health Department leadership, Kelly Weidenbach, Executive Director for Adams County Health Department. Present. Brian Halovic, Environmental Health Division Director.
Present.
Adam Anderson, Epidemiology and Data Science Division Director.
Present.
Darcy Martinez, Nursing Division Director.
Here.
Monica Bewley, Health Equity and Strategic Initiatives Division Director.
Here.
Michelle Harris, Nutrition and Family Health Division Director.
Here.
And Bernadette, please assist me with the pronunciation of your last name. Albanese, Chief Medical Officer.
Here.
And our county attorney is here, Melissa as well. She just stepped up. Melissa Secker.
Do we want to give Bernadette, are we going to tell you give Bernadette a chance to introduce herself or welcome her?
And Michelle as well. Michelle's
Yes.
first like really official regular board meeting. Well, we have two Michelle. Michelle Harris. Yeah, I was bringing it. Yeah. And then yeah, I think we can introduce some of our guests for you, just so you all know in the room. So welcome to Bernadette Albanese, our new medical officer for Adams County. She just started last week with us, and yeah, I just wanted to tell a little bit about yourself.
Sure. So I'm not a stranger to Colorado public health. I've actually been in the state for 15 years or so as working actually in El Paso County and then Boulder County and then Wright County and then here. So I'm it's very seasoned public health physician. My background is in pediatric infectious diseases, but I've actually been doing public health for about 2 years. So back to the clinical side of the house. So really looking forward to working with everyone here and the board and the whole agency under development, and I'm really excited. So thank you.
Michelle, if you'll introduce yourself too.
Sure, yeah, I'm Michelle Harris, and I too with Bernadette have been in Colorado. I'm a native, and I started my career as a public health dietitian in Pueblo, Colorado, with the WIC program, and just kind of traveled my way through Tri-County, through the state health department, and the city county of Broomfield, their public health division, and then back to Tri-County, and now I'm here. So I'm happy to oversee nutrition with diabetes education programming and CFP grant for Adams.
I will have all of our guests introduce themselves, just so you know who they are and what their role is. We are hiring many staff, and then we have some Tri-County staff who are with us today, just as subject matter experts as well. So Barbara, if you don't mind introducing yourself.
Hi, I'm Barbara Winter. I'm the nursing operations manager, and I just started a couple weeks ago. So,
Michelle, if you'll introduce yourself.
I'm Michelle Wilson, and I'm a public health nurse who works at Tri-County Health Department right now, in the harm reduction program.
Hi, Keith Shan, Department of Health Manager, part-time Adams County for the rest of the year.
Susan Keelan, if you want to introduce yourself and say hi.
Hi, I'm Susan Keepley. I'm a nurse midwife, and I currently am the clinical advisor for the sexual health program with Tri-County, and I'll be transitioning over to Adams County as well.
Thanks for joining us. And I think Raquel Carpio is online as well. She is our new communications specialist under the communications department at the county, but she's assigned to our health department. Raquel, are you there? You want to say hi?
Oh, I have, hold on a moment, sorry. Oh, there we go. Raquel?
Hi, can you hear me?
Yes.
Yeah, thank you.
Yes, I'm here. I'm listening. Thank you. Hello?
Thank you so much for joining us.
Thank you, thank you.
We got everyone. Okay, wonderful. Welcome, everyone. Thank you for being here. Next, item on the agenda is just the approval of the agenda. Is everyone, with the order and, after the agenda, is everyone have a good one? Can I get a motion to approve the agenda?
Second.
Who wants to approve the agenda? Yeah.
Aye.
All right, and next is approval of the previous meeting minutes that we received from the September 15th. And,
Motion to refer to the previous.
All right. The next item on the agenda is the monthly financial report, and I will turn that over to Kelly.
Right, and this is, as of September 30th, so they have not yet closed out October, so we'll have an October report in November. So far to date, we have spent, so we were allocated about 2.7 million for the transition for this year under the health department's budget. There were additional funds put in other departments as well, to be clear, for facilities and communications and other staff in other places, but the health department's budget for fiscal year 22 was about 2.7 million. We've spent 332,385, and we have another 423,000 encumbered. So ramping up spending, some of the encumbered amounts are some of the software systems that we're still in process of paying. But we're well underspent compared to what we had requested. So we are right on track and continuing fire. And any questions around spending? Do anticipate that ramping up here in the last couple of months, and then once we will be receiving a bill from the Tri-County receiver for the assets that are transferring over and their market value. It's just based on a larger bill coming through on the summer.
All right, the next item on the agenda is contracts and agreements. And once again, I'm turn that over to Kelly to go over the contracts and agreements that come in.
Sure. So the only contract and agreement that we had for you all to review this month was the backpack MOU. And because that was an unlimited time duration for that agreement, it didn't need to come to your Board of Health. So we just asked for approval for that contract. It would have been in your packet. It's just essentially an agreement to be part of a community group, sharing information, sharing aggregate data, trying to improve access to services for clients and residents. Yeah, just kind of collaboration. Terms between the two agencies.
The agreement with the Board of Health. So there something?
So we would need a motion.
Okay. Wait, so, yeah, I get a motion that approve the contract. So, all those in favor?
Aye.
The next item on our agenda is our public hearings. We have 3 environmental health items, for public hearing today. The first is our on-site wastewater treatment system regulations. The second is our rules and regulations for body art establishment. The third is the fee schedule for Adams County Health Department's environmental health services. When any members of the public wishing to speak, will have 3 minutes to provide comments related to the specific. So with that, let me turn that over to Brian Palovich, our environmental health division director, to introduce the first public hearing. We need to do that, right, Melissa? Or we need to. No, that's good. I'll introduce it and then we'll open it up.
And we'll do a quick overview of some key points from our study section last time and we'll go for the public hearing. So thanks. Diana, for pulling that up. So again, just a few key points just to kind of level set as we do this. Just recall that the board has very specific authority around on-site wastewater systems. That the board shall adopt rules that govern all aspects of the on-site wastewater program, from auditing to investigating failures and that kind of thing, repairs, and that it must be at least as stringent as the state reg 43. As we talked about last time a little bit, just a couple of the very key summary of changes besides renaming it. We have removed sections pertaining to Cherry Creek and Chatfield watersheds that weren't really relevant. We talked about the removal of vault systems from the use permit program. That really was not valuable to have that program. And if you recall, there's a specific requirement that we needed to send that reg to the CPHE for review. After the study session, we sent that to them. And then they got back to us within a few days. By September 30th, gave us the approval letter. That was in your packet. And then in terms of public hearing notice requirements, we got that posted in the Denver Post on September 28th, long advance of 20-day requirement. And then notification to the industry. And so we sent notice to what are called certified professionals, basically everybody who works in the industry. It's those who do installing, it's the designers, those who do septic tank cleaning. We sent that out on October 5th and have not received any comments. And then there's a provision in the state regulation that basically says it's effective 45 days after Board of Health adoption, which puts that on December 5th as actually being effective, but obviously we won't be implementing it until January. So our recommendation here at this point is to adopt the Tri-County regulation with those minor modifications with the effective date of December 5th and implement on January 11th. So back to you. Right?
Thank you so much for something that the presentation was received last month regarding the wastewater treatment systems. I think at this point we will open the public hearing. Do we have anyone who is at this point wanting to speak?
One online. So we'll keep things open for 10 minutes. We'll turn things over to Kelly to start with the executive director's report. And Kelly will interrupt you after 10 minutes. We'll close that public hearing. We'll ask you all to vote on the resolution to pass this regulation. We'll open the next hearing and we'll turn it back over to Kelly. Just want things to stay open to give the public an opportunity to be heard if someone shows up. So with that, Kelly, do you have slides?
I know.
Okay, perfect. So stop sharing.
Coming in, top of my head. Promise to get more organized. Just an update on the transition, we are getting very close to executing leases, for the Brighton office and the Westminster office. The North Broadway office is, we're still waiting for some red lines back from, the landlord there. And hopefully they'll have those executed and they will have to go through public hearing with the county commissioners when they are ready. And all terms are agreed upon. So still working on lease assumptions for those locations. Staffing, we're still at about 135 staff being to be ready and hired as of today's numbers, not including those competitive hires that we're working on. Starting January 1st, we've had a little bit of backsliding in terms of those offers. We lost some folks to Arapahoe County. There's some bidding wars on staff going on, but continue to have a strong response for our competitively hired positions and just continue to fill all the vacant positions that were approved for through fiscal year 2022, and then we'll start posting those for start date of January 1. Just working through a lot of personnel details, hearing that for the Tri-County transferring staff, we have an employee orientation set up for November 16th. A couple of different sessions for people to come to, and that's to enable them to get enrolled in benefits and get some of the building culture and team started, and then we'll do another police orientation starting with January 3rd. But we're in the county's open enrollment period for benefits. We'll be getting them enrolled so that they don't have any breaks in their health insurance coverage. Their coverage will start January 1st. So in most situations, like you for a county employee getting hired on the 3rd, for coverage would not get until February 1st. So we're trying to make sure that the Tri-County staff are not losing that coverage for that 3 or 4 weeks. Just continuing to work with the work chart. All of the division directors are in place. And to be posting that deputy director position for soon with that. Our operations and accreditation manager, Michael Paul, starts on November 2nd. We're getting a lot of award notifications for all the grants through CDBG. So the master agreement is in place with CDBG and that's signed off on. And now we have all the individual grants and contracts that come out of CDBG right through. We just found out, Michelle and I found out this week that we'll be receiving some funding this year to help the transition related costs and her time and other staff's time working towards setting up the clinics. And just generally getting final award notifications, more firmly that funding we're receiving. That's been really exciting. I every day and what's been through. The ways during some of our competitive grants and our made for health grant that we've been in on Big Rock partnership and some of the other county departments, and we should hear first week of November. So we made it to the next step with that. It's just been really exciting and fun, and there's a lot of deliverables with the state, even around carrying up for the contract execution and getting final budgets to them, getting work plans. Lots of different details there. We're still looking at hiring some staff to do monkeypox testing. Just the timing in terms of recruiting and hiring taking a little bit longer than expected. And we'll be looking at working with Tri-County side by side and having some staff offer monkeypox testing. However, the case counts have really stabilized and the demand for testing and vaccination has gone down. We will be at least gearing up for getting those staff trained, having them work on just kind of the transition to Tri-County, working in the clinic, and kind of bridge that gap, or not, I shouldn't say gap, but just bridge the transition between Tri-County and our team. So that will be having those folks in place, getting trained with the Tri-County staff side by side. So excited for that. And I think our monkeypox case count as of early this week was about 46 case patients. COVID numbers are relatively stable. Watching that, it's been more, we've received our funding amount and award for COVID response, which is funding that needs to be spent by June 30th. We're getting around 2.9 million. Working towards what does that COVID piece look like for that short period of time, and the scope, what is the scope of work and the expectations for those work plans look like. So yeah, just a lot of planning, putting a lot of policy procedures in place, and I think we're in a really good spot. So the website should be launching the week after the election. Our IT team is working night and day on election stuff, so the website won't go live. We hope that the social media channels will go live on October 31st, which is on Monday. And yeah, continuing those bi-weekly newsletters, a lot of client specific or in Ramsey's business focused messaging has been going out around the transition. So that would be great as well. Just see what questions you guys have.
Kelly, I have a question about the leases. When you have a space lease, you anticipate a lot of changes to the use of that space, or it's gonna pretty much stay the same use as it was before?
Right out of the gate, we really don't have time to make changes, so we will be keeping all those programs, this really most of the staff in the same locations, not doing a ton of work. I think those agreements, and I don't know all of the details in all of those agreements around like sort of lease improvements and you know what those expectations are, but our facilities team, and they have there's a real estate attorney and Northern County Attorney's Office is working through all those agreements. We're just trying to garner what's our burden for like janitorial services and facilities maintenance, and we're just working through all those details right now. But I don't think there's gonna be a lot of bigger reconfiguration space right now. We'll be participating in the county's this like county-wide facilities study and understanding kind of what our space needs are. We will be tight for space with staff in all of the locations, honestly. So we're hoping that county will be making some plans around either acquiring the buildings or there's some discussion about building a tower out here. I don't know that will be known right away. I actually don't know if it needs to be made by next year. But we're participating in that. I've been providing data around staff in this building, staff in other buildings. But yeah, we'll be tight. We'll be having some of our staff like remote first, or they're working from home most of the time. Yeah, each of the locations, each of these locations kind of have different considerations. That's been like the thing that's making me the most nervous. I will just mention, we also have a plan in case one of those pieces falls through the landlords decide they don't want to. I think it's a very easy ask for them to just pay me. Your county's been a great tenant, we wish you all the same things in place, and we'll catch you in the chat. And so far, I think things are going well, but we're doing some contingency planning, to even provide clinical services like sexual health out of that building. And then this space over here in the conference center also secondary contingency planning space for non-clinical stuff.
You mentioned a little bit of last time, the COVID response.
Yes, so historically, those funds have been used for case investigation, contact tracing, outbreak investigation, connecting people who've been diagnosed with COVID to resource maybe they're quarantined, they need the delivery, or they need support, maybe they lost their job. Most of it has been focused on case investigation. Also, there's been money in that contract for vaccination and other mitigation strategies. I haven't seen scope of work yet, so I don't quite know what that looks like. That's been working on the county side and about the COVID, civil work and expectations might be.
I mean, it's pretty prescribed from the state health department, they come to CDC prescribed, and most of the states and the distributed health departments around Colorado. And, you know, we're generally, we've been sort of following the lead of CDC with a little bit of wiggle room. I mean, Kelly and I were talking, so somewhere like, we still have COVID investigations, but, you know, the lights sort of at the end of the tunnel for all this to settle down, and for COVID probably just become another list of respiratory viruses, like, you know, the long list that we have. Flu and RSV and so forth. But we're not entirely there yet. So I think it's, you know, just trying to target people who are diagnosed with COVID who need help. That's certainly been the transition we've made in Tri-County over the past 6 or so months. You know, once we got either really terrible Omicron situation and strain from last winter. And it was like, you know, people moving on, people making the decision to move on with their lives, and we come along with that. And so some people may get COVID and do okay with it, but you know, do they know how to test themselves if they're sick? Do they know how to find resources so that if they feel like figure out what mental state like family, like where they can call us, or they can seek it out for themselves. But then there's some individuals, you know, based on age and outbreaks where, you know, we may need to intervene a little bit more. Just to see if they need a little extra help and be a little more direct in terms of advice to keep their household healthy, for example, or helping them with community resources. And unfortunately, we have an outbreak which we're focusing on institutional settings. So a healthcare settings, schools, childcare, and healthcare situations where we want to make sure that things are sort of kept nicely contained. Our whole care facility, you know, we just try to don't let things get too out of control there. And again, bridge people to treatment, bridge people to vaccine, bridge people to education. And so that's been a lot of focus, but it is, you know, it's sort of an awkward situation, because it's not that because I said, oh, stop, you know, like we're done. We don't be like, we sort of sitting on full of resources and trying to be creative and really trying to have that work extend with some longevity, you know what I mean, sort of building infrastructure, training. Sorry, that has some longevity stuff, and you know, when things wrap up, we take a whole lot of lessons learned and move that forward. So it isn't, we're not doing the bean counting like we were before with COVID. That's really not where we're at right now. We're just trying to pocket high risk situations where having, you know, outbreaks are having a problem. Folks have been very heavy on, you have to consult with, like, you know, do somewhere they're older, they want like, want to make sure they know how to do this. Like, you really should think about treatment much. Like, let me give you some information, talk to your provider, you know, and try to do some outreach. And then some folks, you know, we encourage people to try to, you know, stay away from others and stay out of work, and we don't know that it's like, you know, and we're not like the police, but, you know, we just try to educate them, and hopefully they make good decisions. And it's very much about managing the cost, but it's such a good your household when they have it, to make sure they're ready for that. Pediatricians for anticipatory guidance, but look ahead for what this might be for the next couple of weeks for you. And make sure you take care of yourself, and then and making sure we can help, and you can help through your household. And you know, really try to make someone else if you can. And you know what I mean? Just try to do something.
So I'm gonna interrupt this conversation for now. We're past our 10 minutes. So Sheila, I'm gonna turn things back over to you to close us out, take us through the first resolution. We'll turn things back over to Brian to introduce the second, and then we can turn back to the executive director's report, or if you all are ready to move on, we can start with the clean syringe access resolution as well. So Sheila, back over to you.
Okay, thank you, Melissa. So we'll now consider the resolution to approve the on-site wastewater treatment systems regulation. Board members received that resolution ahead of the meeting. Are there, and I guess, any last minute questions regarding this, resolution? I'm reviewing it. Okay, well, do I have a motion to approve resolution 2022-004?
I make a motion.
A motion and a second, all right, all those in favor?
Aye.
Any opposed? All right, I think then, that motion passes, the resolution passes. So let's go ahead and turn things back over to Brian again for our second public hearing.
All right, thank you. On the body art. So again, just in terms of some key points from last time, in terms of the Board of Health Authority. Right. All right. In terms of Board of Health Authority, again, that you are not required to adopt body art regulations as you are in on-site wastewater, but nothing prohibits you as a board from adopting body art regulations. Again, Tri-County developed its own regulation with that licensing component that we talked about last time. We adopted that, Tri-County did back in 2017. Again, just recall that other counties, Boulder, El Paso, Jeffco, Northeast Provo, all have done the same thing and adopted local regulations. In terms of public hearing notice, again, we posted it in the number of posts. We met that requirement September 28th. We also provided notice to all of the body art establishments. That was sent out on October 5th, and similarly, we did not receive any comments from the industry. And as opposed to OWTS, there is no formal CDPHE review process for body art regulations. So therefore, really the recommendation again is just to adopt the Tri-County reg as it was developed in 2017 with no changes and effective January 1, 2020.
Thank you, Brian. We'll now open the public hearing on rules and regulations for body art establishments. And members of the public who wish to comment, use their hands now. Okay, so then we'll start the 10-minute time, and you can go ahead then, I guess, then turn things back over to Brian. No, we're going to Kelly again.
And we had stopped at a point where Kelly was finished with her presentation, so any further questions, and if not, we can turn things over to Darcy and Marty.
Further questions for Kelly? Well, then let's turn things over to Darcy.
Some emergency pages still went through. No, thank you.
Good, okay. Well, I am here to talk about the syringe access program and what we think it will look like for Adams County Health Department. We look at the model of Tri-County Health Department, lessons learned, kind of some of the issues that stand out for Adams County and sort of make it ours. So I'll talk to you a little bit about that, but we also have a resolution to approve a syringe access program. It's number 2022-006. And next slide. Generally, I'll just go over an overview of the syringe access program, the benefits of the syringe access program, relevant data to support a syringe access need in Adams County, Colorado statutory requirements for syringe access, the current work that Tri-County Health Department Aurora Syringe Access Program is doing, and some of their results since they started in 2016. Future work for Adams County Health Department, and then just kind of a glance at a service concept for the program. And then I'll wait till we catch up to the third slide.
Two PowerPoints moving at the same time, evidently that. Yeah, doesn't like going back and forth, so. You can only imagine if Kelly gets all her PowerPoints going at one time, how she orchestrates that.
Perfect. So pretty much I wanted to start with, the community health assessment that I think you guys have a chance to go through at some point. I took this straight out of that section, the opioid section. I think what stands out for that section is about 10% receive treatment for their substance use disorder. Lots of fragmentation in the healthcare system. People who die from opioid overdoses, it's been the largest number ever in a year. And also for Adams County, the death rate from all opioids has doubled in 2019 to 2022. And the death rate specifically due to fentanyl increased almost 200% in a single year. So the chart in the top is for Adams County. So you have your prescription opioid blue line, heroin the red, fentanyl the yellow, and methamphetamine the green. And you can see that heroin is kind of that red line. And I asked my colleague Michelle, who's a harm reduction nurse, like what do you see, what do you perceive, and like why explain this light to me a little bit more. And she shared that, fentanyl is kind of dosed into other drugs and at a smaller dose. And so that's sort of the trend now. But since people are dying so much from fentanyl, there might be this rebound where people will come back to heroin and surrender. So we still think that syringe access still should be there and that we're going to get this rebound.
Because we really should probably be calling it harm reduction, because right now people are smoking and snorting fentanyl blues, and so that's another way that you can pass diseases. And so in a harm reduction program, not only do you have the syringes, you have all the other like pipes and straws and stuff to prevent that. And because as right now people are smoking and snorting it, but as they habituate to they get used to that opioid in their system, they're going to need more and more, and they're eventually going to go, people are going to start going back to injection more heavily, unfortunately.
Next slide. Thank you. Terrible slide, but so we're looking at, this will all come together shortly, but we're going to look at HIV in Adams County. In 2021, 1,347 persons living with HIV reside in Adams County. So this is diagnosed with HIV. Of persons living with HIV in Adams County, 942 were engaged in care, which is 70%, and 792, about 60%, had viral suppression. So on that graph, the fourth line down is the state rate. Adams County is the second bar down. So we're second in the state for new HIV diagnosis.
So, because what you want to see is you want to get all those numbers there's a cascade. When you get all those numbers up, so many people engaged in care, so many people have viral suppression. That's how you stop the epidemic. And the numbers that we're looking at, that there's to stop the pandemic is like at least 85% of the people know that they're HIV positive. 85% of them are engaged in care, 85% of them are virally suppressed. So those, they're the same numbers that everybody else has. They're not great.
Darcy, if you're okay with pausing there. We're at time for our public hearing, so we'll turn things back over to you, Sheila, to close us out for public hearing and to vote on that resolution.
All right, thank you. So we will now close the public hearing. And we will consider so we are at the public hearing for the we still have the exact, oh, here it is, the number. The 2022-005 or oh, sorry, 003 for adopting the rules and regulations for body art establishments. Let's see, do I have a motion for that resolution?
Motion there for resolution 2022-003 on here.
And any other things for discussion that anyone has regarding the resolution? All right, all those in favor?
Aye.
All those opposed? All right, so we will go ahead and pass resolution 2022-003. All right, thank you. And so I think we'll then ping pong back to you.
Sorry.
Thank
This is a weird meeting. We're gonna open the very last one. You're good.
We go back to place here where I am. So we are going back to discuss the fee schedule for mental.
So, yeah, just in terms of environmental health fees, again, there are, we discussed last time, two types of fees. Fees that are set by the local board of health, which are OWTS regs, the body art license, childcare facility inspections, pool inspections, land use referrals, and on down the line. Then there are other fees set by the state legislature. Those are those retail food fees, restaurants, grocery stores. So those are the two fees. We've sent the proposed fee schedule to all of our regulated establishments. And we did not receive any feedback either through that notification. Then again, as part of this process, we want to really over the next few years work on a structured, analysis of fees and a formula that we can adopt going forward. And it is in the frequency of review of those fees. Tri-County had historically done it annually with a specific formula, and as we get more and more developed with our financials, we can get a better cadence and system around that. So again, the recommendation is to adopt the Tri-County fee schedule as the Adams County Health Department fee schedule effective January 1.
Great, thank you, Brian. So we will now open the public hearing on the environmental health services fee schedule. And do we have anyone who wishes to speak at this time for the public hearing? Okay, so we'll note the time once again, and then we will return to Darcy's presentation.
Yep, and then rather than interrupting you in 10 minutes, we can consider both of those resolutions at the end, Darcy's and Ryan's.
One other thing I wanted to share about HIV that Dr. Albanese found me the fact earlier.
Today, a person living in Colorado with a new diagnosis of HIV from 2017 to 2021, 15% reported injection drug use as a potential source. Okay, next slide. Dr. Albanese, do you want to add anything to HIV? I know you've had much more time on it.
No, I think Michelle brought it up. I mean, the whole goal, is early diagnosis for lots of reasons attached. So we try to do screening, we try to have people at risk of screening, and of course, trying to do prevention, right? That's tied to this condition. But if someone, you know, by offering opportunity to test, so people can identify their infection early, because the goal is to get them in treatment, right? Like you can live with HIV and live normally with HIV with the right meds and consistency and keeping the virus suppressed in your body. That's the viral suppression. And you can live a lot. And the other fantastic benefit of that is your ability to spread infection tanks, right? And when you're viral suppressed and there's not a lot of active virus in your body, you are much less likely to transmit it, whether that's through sexual activity, which is the more common way to spread, or you know, injection drug use. So there's multiple benefits. So that's the goal. Early diagnosis, get them in, get persons in care, keep them in care, keep them tested, keep them on their meds and all the resources that are necessary to do that. And then prevent, and then for someone else at risk, you know, move to another person at risk and saying, let's find out, you know, try not to do those risky behaviors, of course. This is about harm reduction. If we could eliminate, that would be great, but humans are humans, adults are adults. And sometimes we do things that aren't good. And so then the harm reduction is the, what can we do to make that situation better? Right? Then eliminate, what can we do to make it better? And that's the purpose.
We offer prophylactic medication for at-risk individuals. Is that part of it, or is that very helpful? Or in the long term? That is part of our. Yeah.
So that'll be it for that would be sort of pre-exposure prophylaxis, so it's taking, so if you're engaging in behaviors that we can't stop behaviors, you're engaging behaviors that may put you at risk, then you stay on medication kind of chronically, such that if you do get exposed, medication will hopefully prevent the infection from taking and then resulting in diagnosis. On your discussion.
Go ahead to the next slide. So, as Dr. Albanese explained this to me, this is the tip of the iceberg of chronic hepatitis C in Adams County. We're looking at 105 cases of chronic hep C in 2020, with a 5-year incidence rate of 29.4 per 100,000 person. And we see this dip not because we don't think that it's there, it's because of people not really seeking treatment or getting diagnosed by not wanting to visit to get screened. And that's why we see that dip, and we see that in law enforcement. So that's how we think.
So these are newly identified cases. So I think that Darcy was referring to the iceberg. So the newly identified are like above the water, and all the ones that are already infected is like gigantic wall of iceberg below the water. And there's a lot of people with chronic hepatitis C infection. Some know, and some don't, because it can be quiet for a long time until it hits your liver, injures your liver enough that you start developing your symptoms. That should take years and years and years, but in the meantime, they're contagious. And so we try to identify you and you know, the process of being identified and infected like HIV and care, that's way more sophisticated than it is for hepatitis C. Like they're a little behind the times in identifying them with chronic hepatitis C, which is a while, iceberg below the water. But the process of treatment stuff is way more complicated, and so it's not as successful in some ways as HIV. So there's a big cohort of persons who are hepatitis C infected, and when you look at when we get people with new hepatitis C infection, it's very strong in injection. So that's a real group cohort of people who we have to be particularly careful about. And so the trends have been injection drugs and younger adults, which is not a good combination.
And it didn't, remember, it didn't used to be that,
It
it
used to
used
be
to
that.
be old people.
Yeah, now it's younger folks, and so you get a 25-year-old injecting drugs and sharing needle.
And
they get
snorting.
hepatitis- You know, they get hepatitis C infected, like their life is, you know, that's a long time. And at some point, without intervention, they will have a liver failure, like it's going to happen. If you get it when you're 60 or 70, well, you know, then it's Mother Nature, you know, playing games with you. You get it when you're a young adult, you're gonna have liver failure, like it's gonna happen. And so, you know, and if that's the target group for, harm reduction, again, it's out of injection drugs, but in the meantime, at least offer them clean syringes as part of the package of getting them tested and trying to get them into drug treatment and mental health treatment and all the things that are kind of all these programs. To see if we can not only get them to change their behavior, but again, harm reduction, if they're going to still inject. And will at least make a little bit, potentially make a little bit of an impact.
Okay, next slide. So, syringe access program equals disease prevention, harm reduction, and saving lives. It's a community-based prevention and intervention program. It also has a component to increase safe disposal of used syringes, protecting police officers and the public from accidental exposure to bloodborne diseases. And so for the initial resolution that Tri-County did, they did have to go to these services or to, you know, the law enforcement and say, you know, we need your buy-in, and they definitely, based upon that transcript, had big buy-in. It also reduces syringe sharing amongst people who inject drugs, decreasing rates of HIV and hepatitis C, creates a safe space for people who inject drugs to represent one of society's most heavily stigmatized populations. And people who inject drugs experience disproportionately high morbidity and mortality from manageable infections, including viral hepatitis. And it does allow us to enhance testing for HIV and hepatitis C and provide referrals at the point of care for needed resources. Next slide. And so other harm reduction strategies that we do at these points is Narcan and fentanyl test strips. Next slide. So some of the things we emphasize and what CDC emphasized in their syringe access programs, which they call SSPs, is they save lives by lowering likelihood of deaths from overdose, provide testing, counseling, and sterile injection supplies to help prevent outbreaks for other diseases. They're associated with a 50% decline in the risk of HIV transmission. Users of the program are 3 times more likely to stop injecting drugs. Law enforcement benefits from reduced risk of needle stick, no increase in crime, and the ability to save lives in preventing overdoses. And when 2 similar cities were compared, the one with the program had 86 fewer syringes in places like Park. Next slide. Okay, so this was Tri-County Syringe Access Program metrics in their annual reports. And they had, for Adams County, 56 new number of unique participants in 2020. Number of syringe access encounters, 125. Number of syringes dispensed. They dispensed in Adams County, 8,499. The number of syringes returned was 8,086. Percent of syringes returned comes out to 95%. And then the naloxone kits that were provided were 38 in Adams County. The number of HIV tests performed in their metrics for 2020 was 34. And then 12 hepatitis C tests. And then the naloxone reversal rate, that wasn't by Adams County, that was altogether, wasn't able to break that out. But I think the numbers are still powerful. So they gave out 201 naloxone kits. 30 reversals were reported, giving you a reversal rate of 15%.
And I don't know if you have anything to add to that, Ray, because
I would just say that all these rates that we started in Arapahoe County and we expanded to Adams County. We're doing syringe access on outreach, but we don't have a fixed site, so people are carrying around a backpack and they have like 10 syringes, so they can't get the numbers quite as high. And we were looking to get a fixed site when all this started happening, and so I think if we had a fixed site, a place where people could come and exchange large amounts, these numbers would be much higher.
yeah, next slide. This
So
will be
all
perfect.
those are people from Adams going to Arapahoe County?
So no, it's just that we only have the fixed site there at 1475 Lima. So we only have the one fixed site. It's in Arapahoe, across the street from Adams, because it's in that weird part of Colfax that. And our clients go back and forth. Some days are in Adams, some days are in Arapahoe. But I think if there was a place like, I don't know, I mean, up here or somewhere where people could go over there on Pecos and by the turnpike, or I'm just thinking of where I know where people hang out, that you'd see higher numbers.
On the next slide, I can show you a map of our lack of access. So that's me sitting in my office, going to this North American Syringe Exchange Network to look at if I wanted to do syringe access, where I could go, and there's nothing for a hot minute around me, where I could go to do that. And that green, I think the green one was the Tri-County San Luis site. And then for naloxone distribution, once again, I'm by myself having to travel very far to get access. Also, so obviously I feel like there's a need. So next slide. So what is your charge tonight? You are here. You are in charge of looking at this resolution, and in terms of its establishment of a syringe access program. So how this reads is grants, county or district board of public health have power to approve a syringe access program by an agency or nonprofit via agency contract. So we'll need approval to do this, and consultation should occur with community stakeholders. But Tri-County already did that for Adams County when they initiated the syringe access program anyways. And I felt like the tempo and the need, we could take that stakeholder content and apply it. Other applicable statutes or regulations are the statewide injection paraphernalia exemption, which grants that participants the right to carry a clean and used syringes without it being a crime. And then decriminalizing syringe has shown to reduce overall rates of needle stick injury to law enforcement by 66%. The other one that comes into play is Senate Bill 14 for third-party naloxone distribution, which allows us to distribute naloxone as a third party and include friends and family members of opioid users and giving them naloxone to administer also should they need to on somebody else.
So so what if they stop, like maybe someone who looks like a homeless person on the street, and the police officer is going to say, do you have any syringes on you? And before this, they're going to say no, because they're going to get popped for a paraphernalia charge, which could, if they have open warrant or something, could end them back in county jail. So if they say yes, and they are part of the syringe access program, they're not supposed to get charged, but then also it saves the police officer from patting someone down and getting hepatitis C from the needle that someone didn't want to tell them about.
Okay, so next slide. This is our vision for our program at Adams County. Our target population definitely is people who inject drugs in Adams County, along with all the other stuff that comes out of that. Our locations, Commerce City, Federal Heights, Thornton, Westminster, Brighton, North Glen, unincorporated Adams. Who's the staff? We're the staff, Adams County Health Department. Our core services would be education regarding infection and overdose prevention, service access,
HIV and hepatitis C rapid tests and prevention counseling, provision of sterile syringes and needles and disposal of used materials, and the provision of an ID card. So what we didn't tell you is that when they do get syringe activated, that card, so that allows them to have without that criminalization. HIV prophylaxis. We were talking about PrEP. So right now we'll refer, but when we get that program going. Mental health, substance use, and medical referral. Okay, I'm for sure you guys know. Also to resource some wraparound services in that same point of care interaction, which is direct provision of naloxone and fentanyl test strip, a referral to other services, including immunization, family planning, WIC, access to care, and other community resources like housing. And that is our brief overview of the Center Access program. And then any of that.
And this can be short, it doesn't have to be long answer, but this, what is the stakeholder outreach by Tri-County?
All Adams County, I mean, I'm just thinking in Adams County, it was. I forget what they're called, the mental health. What are they called? Community reach, Adams County Sheriff, all of the, off the town's local police departments. The DA, all the people around in the justice system. It took us months. It took 6-8 months to get it initially set up down in Arapahoe County, then it took another 3, we knew how to do it a little bit better, it took probably 3 or 4 months to reach out to everybody in Adams County that needed to be reached out to. But by then, like the Arapahoe County people were saying, like the Aurora police chief was like, hey, this is a great thing, and so and I'm trying to think if I missed anybody else.
We have the county.
And Adams County was involved in it, yeah.
I'm just curious, what if the plan long term really try to get a bricks and mortar location? What's the initial kind of rollout that process look like for you? I think this is a really exciting program, but just thinking about year 1 or year 2, really, where do you see that starting off?
Well, like right now, we have, like I said, we already do outreach, so there's people that go out to the camps and stuff on foot. But just if we, what we do, like what we do in Aurora is Monday, Wednesday, and Fridays, 1 to 4 in a community, another community organization lets us use. We were paying, and then they decided that we don't pay, but we just need a space to have all the stuff that because all that stuff that was there, we do that every time someone comes in, ask them all those questions. You know, if I were to walk in today and say, I want to stop using drugs and I need to go into treatment, I can't get there. I mean, so we have to bridge them to that. And so everybody that does the work is working on sort of different of being able to bridge or help those people in a non-judgmental way. As you know, they're probably the most highly stigmatized group of people in America right now. And so we need a couple places. It doesn't have to be a big, doesn't have to be a lot. It doesn't, I mean, where we're at is like a kind of a dumpy room. And they're happy to come in and there's a bathroom and it doesn't have to be a lot, it doesn't have to be often, but it just has to be that they know every Tuesday you're on Pecos and 60th. I don't even know what's at Pecos, I don't even know if that's in Adams County, but that you're there every Tuesday. And so some of the people can come get that.
Sounds like you could like almost rotate, having a couple days a week in one location and another
Except
location.
that there's so much stuff. That's the beauty of the fixed site, because there's a lot of stuff. We used to, this community organization that we have it in now, we used to have to take the stuff out, we had to carry these huge bins in and out every time because they didn't have space for us to leave it. So it would be nice if it was something that we were in, I don't know, we're somewhere Mondays and Wednesdays, and then we're somewhere else Tuesdays. And like we have in our office down there at Colfax and Chambers, there's just a room that's just filled with syringes, alcohol, everything that you need. And so I guess we're gonna get a third of that, or however they're dividing it up or whatever. But so we need a space to store that here where the harm reduction people are working, and then we needed a space where that can go out and stay.
Yeah, so Kelly and I had this conversation today about brick and mortar and also mobile, I don't know if you've seen TRICARE's prevention point trailer, something like that, in a couple of different ways. But we thought about, we have a couple locations that we could start off with, which would be Commerce City and here and there, and just kind of try to have that as our starting, and so we find a central point. We also want to make sure we have enough storage, and then we also want to offer people some remote options also.
I'll just mention I'm serving as the vice chair of the regional opioid council for Adams County, and we just went through confirming allocations for certain strategies using those opioid funds, and harm reduction was initially allocated 20% of the 2023 funds, and so I think there's a lot of opportunity to take a look at what that funding can do, and maybe expanding, and whether that be, I see long-term future, both brick and mortar and those mobile units, which might be trailers or vans. But I think, yeah, like Michelle mentioned, no fixed site in Adams County right now. But I think we want to take a look at where those low hanging fruit are, where there's community-based organizations that are willing to have us there, and willing to.
And when people can walk or bus too, because typically, although one of the reasons we have a fixed size is sometimes for housed people, they tend to have like large amounts, because they don't come as frequently. So, and then because I just keep forgetting how big Adams County is. We're here, it goes another, what, 50 block, or, it goes all the way to what, 100 and something, 50th, 80th. It's just a lot. So there's a lot of space. Working with the homeless navigators in the county to see where they know where there's a lot of people at, or maybe where. I know that when Adam was at Tri-County, he had done hotspots for us where there was overdose or where there was homeless camps, and that was where we tried to set up.
So you talk a little bit about sort of like, where the team's been working on the Tri-County side that maybe isn't along that Colfax border.
So they routinely, that's every Monday, Wednesdays, and Fridays, but typically in the mornings, because it's either, well, in the mornings in the summer and in the afternoons in the winter, because it's warmer in the afternoon. We go to different camps and they move around pretty frequently. The ones that I'm most familiar with are the ones that are sort of down along Sand Creek. Is that Adams or Arapahoe? Yeah, Sand Creek. And so we've been out with along there at the Commerce City office. There's a bunch of paths that take you back up onto the South Platte. There's a lot of, and then there's a lot of places that we don't know. There's places they've been out there. I keep referring to Pecos, and they're at the Turnpike, because there's a large group of folks that come in and out of there. they just kind of, and the thing that's unfortunate about that outreach, we're not big, we can't go there every Tuesday, we go there like on a rolling. Like every third Tuesday, we can get to there because we go to all the other places. And then we might go somewhere and that camp's been. Tossed and it's gone and we have to reestablish. We had a lot of, we learned our lesson with, when we first started, we were working with some organizations. That people didn't trust, and so then consequently, they didn't trust us. And so that made it a little hard in the beginning, and then we sort of kind of parted ways with some organizations over their sort of like theories or their, you know, like their hard. They were not into harm reduction, actually. They were more into like, they need to stop. It's like, well, yeah, they do need to stop, but they can't just stop. Anyway, so it's a huge thing around trust. I think that the homeless navigator, her name is Heather. I don't know what department.
She's an HHS.
So they have a huge amount of trust for her, and she has sent us to different places, and she has helped us find different places.
Yeah, so the Adams County, hi, I'm Barbara. I also do immunizations at Tri County, and so we've done some stuff together with harm reduction. The Adams County Health and Human Services Department has a really strong outreach program. And so they're like resource fairs. They have a couple of locations that both harm reductions and immunizations have done services in partnership with them.
Just one question I had, just coming from the hospital side. I'm seeing a huge rise recently in IV drug use, again, so talking about the tip, it's something I'm seeing already. And so one of the things I just have is, have we started working with even just in the East Management Support teams?
There's actually a lot of the CHAP grants and some of the grants have, that's a component, case management for people who use drugs. Again, that's gonna look very differently than, you know, what I think is case management is you start taking methadone and live in an apartment, but so you have meeting people where there are, and maybe getting them to be on time for their appointments using the bus. I mean, yeah, so we are working with people, and every single time someone comes in to see us at Sprint Access, we say to them, you know, do you have any, can I help you get into treatment? Can I help you? And so every single time, so that's really normalized, but I don't shame them for what they're doing, just to know that I have the knowledge, the resources. With Adams County being such a big county, it'll be interesting because like right now there's a program you can walk into the emergency room for the university and they'll start you on Suboxone that minute. But people that live in Adams County don't want to go down to Aurora, Denver Metro. Because I work with people who are HIV positive. That's another part of my job. And they're always like, I don't want to go there. I want to go here. And we have one provider up here that will see HIV clients. So yeah, that's an issue. But it's a good issue because people are willing to talk about it. I mean, I think with the fentanyl that's coming in and that's not affecting the people who inject, but you know, it's in the party drugs, it's in the cocaine, like what the deaths in Thornton this summer, things like that. It started to make everybody see that it isn't just those people, it's something that affects all of us, and we need to all kind of work together to figure this out.
So just a kind of comment, so a similar presentation numbers from Boulder County. I was surprised how much items stuck out. How many people are over this? Some probably some coordination with.
Yeah, that's why when we first started our syringe access program, Harm Reduction Action Center, which is the largest one in the state, they're kind of in downtown Metro Denver. They were always like, we have so many participants from Adams and Arapahoe, and she was honest and honest and honest. And the previous director was not interested. And then when Dr. Douglas came, he said, of course, we're going to do this. And so I know Boulder has a huge, Boulder was doing it before it was legal. Boulder was doing it like, you know, back alley secret. They've been doing it forever. And we could say we wanted to be like, I mean, they have like 4 fixed sites and one of them is a fixed site in the evening and it's, and on weekends. So, we could aspire to do a lot of the stuff that Boulder's doing.
In one of your slides, you talked about either the county taking it on or partnering with a nonprofit. Talk a little bit more about that.
Yeah, that's just how that bill is worded.
So like Harm Reduction Action Center is a community agency and they do it for city and county in Denver.
To kind of contract out.
So are you looking at that or are you looking at learning it through the county now?
Through our health department, I think we have expertise. I think at least to start.
The discussion at the regional opioid council today was that there were likely not that many CBOs that would be willing to start that up. And so I think I would love to see more agencies offer it. And I can, I think first and foremost, we need to get the health department set up and assure that the continuity of what they're doing now is continued. And then I think we can look at building this out further within the health department. And I think long term, we can look at providing technical assistance to other CBOs, maybe can start off by this.
Well, and what we've been noticing with the big rise in the fentanyl deaths that aren't typically among people who inject, not that population. The health department has a little bit more, I don't know if it's gravitas, if that's the right word, but people are willing to hear what we have to say because we are the health department. I don't know, they didn't really want to hear what we had to say about COVID, but they do want to hear what we have to say about fentanyl. So that's been something that's really, with the schools and stuff, when they around the fentanyl.
And I heard a large request for just, getting more naloxone and the fentanyl test strips in the schools and just getting that out more. So I think there's a lot of opportunity for the health department to take the lead, not necessarily to be the only group doing that, but for us to take the lead.
And on October 29th, which it will be at North Middle School, which is a school in Adams County, we're having a huge facing fentanyl. I don't know, it wouldn't be called a fair. It's we're right, this week we're in Aurora Public Schools and next week we're doing work at Inglewood Public Schools. The school districts have been contacting us asking, what do we do? I'm kind of passionate, I'm sorry. One more thing, the blues, the fentanyl, they call them the blues. And you can get one tablet on the street for anywhere from $2 to $10. So you can't buy marijuana for that, you can't buy alcohol for that, you can't buy cigarettes for that. So very cheap. So it's kind of scary for kids.
Thank you so much, Darcy, for the presentation, and Michelle for all your, and we all have a lot of, like you said, passion and expertise, so I feel like we're in really good hands going forward. So I think now we'll kind of officially, if we haven't, closed the public hearing. And then we can, at this point, we can consider the resolution to approve the fee schedule for environmental health services. Do I have a motion to approve resolution 2022-005?
Motion to approve resolution 2022-005.
All those in favor?
Aye.
Oh, I forgot to open it for one last round of questions. All those opposed? Okay, I think on that, the resolution 2022-005 passes. And then next we'll go ahead and vote on the resolution to approve Adams County Health Department clean syringe exchange program. So I have a motion. Motion. And further discussion or comment? Okay, Dee Dee. So, everyone good? All those in favor? Aye.
Aye.
Anyone else? Okay, so we pass the resolution to approve as kind of program.
There's a question, I know it's all in the planning process, but the site here. With Arapahoe County, you guys gonna live on with Arapahoe?
I don't know, but I'm imagining that it's still gonna be there. Is it Colfax and Lima, which is kind of a great area for it to be. And I'm pretty sure they're gonna keep that program in that building there. The reason we don't exchange that, just the health department itself, they do in Jefferson County, they just actually exchange at the health department. But the reason we don't at Tri-County is because it's a guarded building, we have to go through, and it would just be kind of a mess.
Now it's time to move on to anyone who has any comments, announcements, or any other business. Anyone, would have any further comments?
Because just something kind of long-term, and I'm just hearing this a lot from health systems right now, is, we're still dealing a little with COVID and 25 cases have stabilized. And then that topic coming out, of course, is Ebola. And there are a lot of health systems right now that are starting to do some planning. And I think that there's just a lot of questions as to what is that going to look like, leaving with Tri-County closing and with Adams County starting back up. What work now that's being done, how is that going to transition? And are there early discussions maybe between facilities in there? And so I know it's very early, but we've seen a couple of hounds come out. We're hearing it from healthcare coalitions. And for some of our health systems a little bit larger. So Kelly, you may not have a whole lot now, but I just think long term that may be some conversation because I am hearing a lot of that. Just because I do think it's a hot topic, but with that transition conversation, I think is really raising a big question mark for a lot of facilities.
Yeah, so I just think for the switching. So, right, a whole, right? Yeah, okay.
Let me try that one.
Okay, no, so, yeah, we can't even see the stop one. But you see, the urgent, from another is kind of unbelievable, actually. So there's an Ebola outbreak in Uganda, and relative to the situation from when we had the large outbreak in the Congo, at the moment, this is much smaller. We hope, of course, everybody's nationally, the regional, so forth, we're all hoping it stays that way, but, you know, it may not. So there is some, dusting the protocols off the shelves, from before. I mean, there was some intense. COVID was intense just from the sheer volume. This is intense because of the sheer severity, right? And so we're all sort of dusting our protocols off the shelf from how that went. And, so this, you know, and the CDC moved pretty quickly to restrict how travelers from the affected regions come into the country. They're only now permitted to fly in. There's no direct flights from Uganda to Colorado. So, but any passengers coming out from the affected region now must go to 5 airports, which doesn't include DIA, it's JFK, Atlanta, Newark. Houston, and adults. So that's helpful, and then persons, basically getting on the plane, which is University of CDC. It's not a perfect system, but sort of a bit of the background of what we had before. And then if they had a significant exposure, within an affected region, they're not permitted to continue travel. So those public health jurisdictions are gonna end up with some travel, right? They're just not allowed to proceed until they finish the 3 weeks of observation. If they've had, low risk, meaning they're not from an infected area, they're home in the country, they're not from an infected area, and so forth, with different criteria, then they're allowed to, so that's how they ended up in Colorado. There's been, in the low 20s, travelers that have come to Colorado already. That are now, and again, so these protocols got moved into place very quickly. And so they are being monitored by CPHE. We will be alerted, so right now we're alerted to go in Tri-County. But depending on how long this lasts, you know, we, January, we get alerted, say, and eventually we may end up taking over the travel monitoring, which means we gotta keep it on for 3 weeks. And it means to stay in touch with us. And we will be sending you calls or texts or whatever, checking in and see if you have symptoms, you can take a temperature every day, things like that. And so that's where the public health stuff is. And then the handoff to healthcare is either 2 things. We have someone under monitor who's being monitored who develops symptoms, and then they need to be evaluated, or something slipped through the cracks. And somebody shows up in an urgent care or an department, and we have a minor freak out, right? So, so the protocol for suspect people who have symptoms, who have a legitimate, you know, the travel, it's not gonna be like, you know, I'll say you to New York City, you know, I live in New York City, I came to Colorado, I can't avoid, like that doesn't apply, right? You know what I mean? So, and sometimes it takes some work for CDC to put together, but we tell flight information and when it's confirmed, we will on that plane, you know, and we work very closely with the CDC over there. So so we're polishing all those protocols, CDC is revisiting, but having done this in Tri-County, basically it's a say the cleanest situation, someone traveling, they're being monitored, and they say, I have a fever and headache. And they're supposed to contact public health. And that initiates a big wave of activity to figure out what's going on, and that happens with CPHE, the hospital, potentially EMS, depending on the symptoms, and the local health department, and we have a powwow, and this could happen at 3 o'clock in the morning. I don't know if I can tell or not, what it is, in the middle of the night, where we just have that conversation and saying, well, hold on, they need to be evaluated, where are they gonna go and how are they gonna get there? And the hospital, are you ready? To receive the patient and put them immediately into isolation and put on big, you know, PPE gear, look like a moon suit, and then get them evaluated and get a test in the state lab, which will come back. Right, the state lab is already set up, they're ready to test, they're ready to test for the strain of the virus following the outbreak in Uganda, they're ready. So you know, this planning started a week or so ago. We're waiting for CPHE. Hopefully not go too much and change protocols too much from what we're accustomed to from before. And I said, I don't know what these called, and just, you know, you just work it out. But what degree, so that's the public health side, and what degree the hospital side, the receiving hospitals. So it's, you know, it's going to be an issue for the children, is, I don't have the actual CPG part working on the list in terms of where we would try to send the patient first. So if they inadvertently show up at AV, any hospital is supposed to be ready. That didn't go so well before. I mean, they got caught up, you know, but it was rough in the beginning. I think now, because we're expecting this like not to happen, or be like one, maybe, like we can handle it where we want them to go, and we will have an ambulance ready to transfer them properly, ready to go. So, but you know, I mean, we're not gonna get like, oh, we have 50, we gotta sit there with a map, and so like it's gonna be. We live in the middle of the country, so we're not sort of, you know, the hundreds of where folks are coming to is. So we're not starting from scratch, which is good. Things slipped through the cracks last time, this is bad. Meaning that, you know, traveling just somehow gets here, arrives in the country, and you find out after the fact that they drive around the country, it's just, you know, you're kind of all over. But we're not starting, and the hospitals aren't starting from scratch here, especially with the main regional Ebola treatment center, which is under health. The issues and ensure the proper cases, for example, in our area. And out west, I just started with visa. You know, what I mean, there were some centers that were like super duper amped up. So that's where we're at, so, you know, we're monitoring now.
I think Adam has something exciting to share about a grant which we're looking to, that will help.
Oh, thanks. Yeah, I was just going to add after Bernadette finished about Ebola is that we have the opportunity to get some through CDPHE on dealing with exactly that, with travelers coming in and assisting, but the funding is pretty flexible in terms of how we would use it for travelers coming in with certain types of diseases, and whether that's building capacity or actually providing the materials for like even PPE for that matter, but we'll be applying for that as well.
So public health is a facilitator, yes, right? And we're receiving, you know, if things are going well with the CDC and the handoff to the state health department, we get alerted. We are responsible for the monitoring. And then we facilitate when something goes sideways. And then everything else, you know, and then the care is at the hospital level. And then if Ebola is confirmed, that patient may, depending on the hospital that patient is at the moment, they may get moved, transferred to a definitive treatment hospital, which would be the one that I mentioned. And then we assist the hospital with ensuring they've got their infection control, and if something goes sideways in the hospital, and we think there's an exposure, they're still going to take a lead on an investigation about potential healthcare worker exposure. But we would help. But you know, this is, you know, once a person with suspect Ebola is ill, we're playing a supportive role and ensure that, and we're gonna play with communication, the media, and how we try to get out, and so we do a lot of that peripheral stuff. But that patient is, in terms of taking care of the patient, it's definitely but there was so many trainings for the first time, and then, you know, and then just lots of false alarms. False alarms really get you off. I really need you know, maybe a traveler and I have a bullet, you know, malaria cases, gargle bullet and kind of malaria. But that false alarm, it does amp you up, but you know, the hospitals I've been working with very closely with UCL, for example, and we drove with them. It was unbelievable what they were infrastructure, you know, shut down half of an ICU and was made that their whole wing. It's pretty impressive. So they're all, it wasn't long enough ago that everybody's gone. So, and I think we're probably going to do it well.
Hearing any specific concerns or just the.
No, I think it's just curious transition. I mean, all the hospitals are just not their playbook. They have enjoyed leading with some that roll out at a hospital already. So I mean, we're doing the same. It's just in that initial assessment, but I think it's just that question mark. There's still not a ton of speech going out other than, hey, you should start messing off those videos. But because the partnership with has with Tri-County for these facilities, they take a lot of lead because take a lot from the health department versus from the state because there's a lot of that partnership. And so it's just more of, if we start doing this work with Tri-County now, and not now, but a couple of weeks from now, as we continue to test out playbooks and talking through some of these processes, what's that going to look like as we make that transition? And are there some concerns or things that they need to be aware of, maybe thinking about 3 months from now, if this is continuing and hopefully it doesn't, hopefully it kind of isolates and we're able to avoid it. What are some of those things that maybe they need to start incorporating in their planning processes now, knowing that the transition may occur in the middle of it? And so it's just questions around that aspect, not that there's an immediate need, but it's just thinking through what does that communication look like? What are maybe some of those shared protocols or processes that we're gonna incorporate?
I think once a horrible public health terminology, so PUI, person under investigation, right? All the hospitals like PUI, and that's like I'm sick and I'm unable. right, and I'm not diving into, right, so it's the PUI protocols. That, that's gonna come out fairly soon, and I don't know, CPA, I was a little sheltered started, it was pretty good last time. But, you know, they're looking at it, right, and then we'll see what these between, and then I think, you know, at that point, you know, Trent County will have the opportunity to have more one-on-one, you know what I mean, we're gonna have a playbook. But it's this cool, it's this initial coordination. Because once they're in the hospital, public health are gonna test. And then the hospital's gonna manage it. You know what I mean? And that's ultimately what'll happen, and then again, media side, and then contact investigation. Issues in the hospital, and then, you know, just refresh on the infection control piece. But, so I think right now there's no immediate disruption, and, you know, it'll take some time to see what the burden of travelers are into the United States and how much state health departments can manage. And then how it gets passed on in terms of monitoring for local health departments. But I think once we have the PUI protocol, then there's a little more to work with. But I think, you know, Michelle and Sarah, they're gonna be connecting with, especially our main regional hospital. And kind of see it, and whether that turns out into some exercises and stuff, I'm not sure, maybe it will be. But I, you know, we almost in some good way, we still have a couple of months, you know, and I think that a lot of planning can happen in that time. So I think for the hospitals, this is important forward and get comfortable with the protocols for isolation, and heavily the protocol.
I think the messaging really is like, part of that, many of us were in a Trent County role and are involved now, Adam is overseeing the community CPG program. And now that Bernadette's here, they're sitting in those meetings with CPG, working on planning. We're not a health department yet, so we're deferring to Trent County for those communications. We have many staff that are feet in both places right now, like the staff that are coming over in January will have been involved in the Trent County side, and then including the health department. So it's really like it's the same people that you're dealing with now that you've been dealing with over here. We're all up to speed already, and it will just be a very informative.
I just want to let you, I mean, it's just know that topic was especially coming out from multiple health systems, just kind of bring it in. It is group and let you know.
Yeah, I think we can do some messaging. Bernadette and I've been kind of making a list and talking about this messaging of those institutions around the communicable disease and sort of, yeah, the pandemic and outbreak response. I think this is where they can reach out to.
Further questions from leadership or? Okay, great. So with that, we'll adjourn the meeting tonight, and our next regularly scheduled meeting is Thursday, November 7th.
I would like to remind you all for that meeting on the docket, we have Kelly will be presenting the community health assessment from the Trent County budget, and we're getting a dive into the health outcomes for benefits. And yeah, there's other things that you all would like to hear. There's plenty of other content. So, yeah.
Quick motion to adjourn.
Second.
All right.
For the minutes, Thanks, everybody online. We're gonna close it out now.
Good night.
Have a good night. Thanks for joining.